Good afternoon and good evening, one and all. So this is the first part of our neurology sessions. It is on the basics of neurology and localization of lesion in dogs. So in neurology, the signalment, of course, you all know signalment history is very important because most of the neurological diseases are breed associated. And for example, the disc herniations are more common in Dachshunds, Shih Tzu, and Beagle. And epilepsy in case of Golden Retrievers, Labrador, and German Shepherds. Of course, degenerative myelopathy, you are well aware, it's in German Shepherds. Hemi-vertebrae is more common in Boston Terriers, Pug, and English Bulldogs. Hydrocephalus, more common in Lhasa Apso, Pomeranian Pugs. So breed is more important. And coming to the age of onset, you all know about it. Congenital and infectious is more common in puppies, and degenerative and neoplastic disorders are more common in older dogs. Okay, just by looking at the progression of the signs, we get a clue about what type of etiology it may be. For example, this graph shows the clinical signs and the duration here. If the signs is very acute and sudden clinical signs, which is very acute, it may be a trauma or vascular. Trauma, you know that. Vascular in sense, I mean a fibrocartilage emboli from the intervertebral disc, occluding the blood supply to the spinal cord, causing ischemia. And next comes to infectious. Just not as acute as you see with trauma or ischemia, but it is somewhat acute and then it improves over a period of time. Whereas if you look at an anomaly, a congenital anomaly, it will be a very static sign throughout. Whereas with neoplasia, the signs will slowly progress. It will worsen. It won't improve. In case of a trauma or infection, over a period of time, it will improve. But whereas in neoplasia, gradually it gets deteriorated. Same thing holds good for degenerative, which is much slower than neoplasia. So once you see an acute sign, so first thing, and that sign is improving in the coming days, then you can think about trauma. And same thing holds good for infectious. Whereas if the signs is keeping on deteriorating over a period of time, it can be a neoplasia or it can be a degenerative disease. Suppose if it is a metabolic, you see some waxing and waning of signs like this. Suppose if it's an insulinoma, if there is a hypoglycemia, then you will have the nervous signs. And once it is not there, you don't see those signs. Okay. So we classify the etiology based on this Dammit classification. D stands for degenerative disease, and A stands for anomalous, that is congenital. M stands for metabolic, and N stands for neoplastic or nutritional. I stands for idiopathic, ischemic, or immune mediated, and T stands for toxic or traumatic. Of course, we have discussed on this. Anomalous is the more common is the congenital hydrocephalus, hemi-vertebrae, all those things. Coming to metabolic hepatic encephalopathy, uremic encephalopathy, insulinomas. The neoplastic, the most common neoplasm seen in the brain is the meningioma and the supporting cells neoplasm, that's glioma. Nutritional, thiamine deficiency, you all know about it. Then idiopathic epilepsy, that is among the idiopathic disease. And ischemic is the FC, fibrocartilaginous emboli, the emboli from the intervertebral disc causing obstruction to the spinal vasculature. Then comes your myasthenia gravis, which is an immune-mediated disease. And T for toxic or traumatic, you know that ivermectin toxicity can cause neurological signs. Metronidazole can cause vestibular signs. Coming to traumatic, it can be a trauma to brain or the spinal cord. Okay, so before going into the neurological examination and how to localize the lesion, we'll brush through the anatomical divisions, the brain and spinal cord. just you recollect your anatomy. And as you all know, the division of nervous system consists of the cerebrum, brainstem, cerebellum, spinal cord, the peripheral nerves, that is including cranial nerves, and the autonomic nervous system. Of course, you know this, the cerebrum, and this is the brainstem, which has diencephalon, mesencephalon, metencephalon, myelencephalon. And then you have cerebellum. These colors are marked differently. You can easily identify what it is. Then you have cerebellum here. And of course, it continues as a spinal cord. From the spinal cord, you have spinal nerves coming out and continuing as a peripheral nerves. Then you have cranial nerves from the brainstem, which comes out and runs. Your neurons are there in the brainstem. The axons comes out and supplies the organs. You know that. Of course, the autonomic nervous system, we are going to discuss what it is. Okay, these are the functional areas of brain, and it is marked there. The frontal. Then you have the parietal. You have the olfactory area. Then you have the temporal area. All those things. And each has its own function. You know that: motor, somatosensory, auditory, vestibular, visual, olfactory. Other than that, you have cognition, memory, afferent input, all those things. This is the functional divisions of the cerebrum. Coming to the brainstem. Okay. So the first part is important for your consciousness and for gait. And from there, you have the cranial nerves, 3 and 4 coming out of it. The neurons are situated there, and an axon comes out from that. Okay, the next part, which comes with that, bonds in that area, it is meant for the consciousness and also for the bladder function. And any lesion there will cause a human sciences bladder, and it responds for respiration also, a part of respiration. And then there comes the medulla area, where almost the cranial 6 to 12 comes out of it, and there is a respiratory center there. Then you have your cerebellum. Cerebellum, of course, it controls, regulates rate of movements, and any lesion there, it can cause an hypermetria, dysmetria. It can cause ataxia. It can cause intentional tremors. Intentional tremors, in sense, what I mean is, if the animal is going into any act like drinking water or feeding, then naturally it develops tremors. That's called intentional tremors. And with the cerebellar lesion, you have something called paradoxical vestibular syndrome. That means you have the head tilt and the nystagmus on the opposite side of the lesion. Usually, in case of a peripheral central vestibular disease, you have the signs on the ipsilateral side, same side of the lesion. But only with that, cerebellum lesions, especially the flocculonodular area of the cerebellum, which, when there is a lesion there, it has an inhibitory action over the vestibular apparatus. Once that inhibition is released, the other side does overdo that, and it causes a paradoxical head tilt. That is opposite to the side of the lesion. That is what we call it as a paradoxical vestibular syndrome. It is common with cerebellar lesions. Then you have sections of the spinal cord. You have the gray matter and the white matter. Gray matter has the neurons, and the white matter has the axons. All those fibers run through this area. And the lower motor neurons are all situated in the gray matter. It is the section of the spinal cord. Okay, this is what I said. You have the dorsal funniculus, lateral and ventral funniculus. The dorsal funniculus usually carries the ascending tracts involved in the proprioception. The lateral has both ascending and descending tracts, mainly for proprioception, touch, pressure, temperature, and pain pathways. The ventral funniculus has descending motor tracts. These structures runs as a sheath inside, just like a fiber optic cable. It runs throughout the spinal cord. Okay, so as you all know, this is the lower motor neuron for the thoracic limbs, and these are the thoracic limb innervations. This comes out as a spinal nerves and runs as the peripheral nerves. You all know about it. You have suprascapular, subscapular, musculocutaneous, axillary, radial, median, and ulnar for the forelimbs. These are the major 6 peripheral nerves which supplies to the muscles of the forelimbs. So this element is located between C6 and T2. This we call it as a cervicothoracic cord. Then you have pelvic limb innervations. It starts from L4 to S2. There is femoral, obturator, cranial gluteal, caudal gluteal, then sciatic, then you have pudendal. All this comes out of it and supplies to the muscles of the pelvic limbs. Okay, coming to the autonomic nervous system, you have 2 divisions you all know about it, sympathetic and parasympathetic. Sympathetic division, usually it is in the it is there in the thoracolumbar segment between T1 to L4. It is there in the thoracolumbar segment, T1 to L4. And this is the preganglionic area where it comes out as the ventral root, then continues as spinal nerve, then as a ramus communicans, and then it joins the sympathetic trunk. This is the sympathetic trunk, and continues as the postganglionic, and it supplies the organs. This is the sympathetic pathway. This is the preganglionic pathway. Just the expansion of this area I have given here, and it supplies the organs. Coming to the parasympathetic preganglionic pathway, it is in 2 locations. One, it is in the, it is from the 7, 9, 10 and 3 from the brainstem, and it runs down, and this is the preganglionic pathway, and usually the ganglia is the organs, and the other part is in the sacrococcygeal cord. It runs out as a ventral node, spinal nerve, ventral bands, then sacral plexus, pelvic nerve, and then come to the pelvic plexus. So this is the preganglionic pathway of the parasympathetic. Then what this does is, these are some of the organs it supplies. For eye, the sympathetic causes dilatation, parasympathetic causes constriction. For heart, it increases the rate and force of contraction, whereas the parasympathetic decreases that. For lungs, that is for bronchioles, it causes dilatation, it causes constriction. For gut wall, it decreases the motility, this increases the motility. For gut sphincter, it constricts and relaxes. For bladder detrusor, that is the bladder muscles, it relaxes, that is this contracts. For the bladder smooth muscle sphincter, this constricts and this relaxes. The penis, it's almost a complementary ejaculation and erection. And for gallbladder and bile duct, it relaxes and then this one contracts. For salivary glands, it makes the saliva more concentrated. This makes the saliva more watery. For nasal and lacrimal glands, this causes vasoconstriction, and this causes abundant secretion. Okay. So before going into the localization of the lesion, you should understand what is lower motor neuron and what is upper motor neuron. So lower motor neuron, actually it is an efferent neuron connecting the CNS to the effector organ, which is the muscle, and it is its nucleus is in the gray matter of the ventral horn of the spinal cord, and from here it axons leaves and continues as the spinal nerve and then as the peripheral nerve and joins the effector organ. Okay, and synapses is the effector organ, muscle or a gland. And that is the last neuron in the chain of neurons. After that, it continues as axons. So when there is a damage here, this particular action itself is lost. So what happens is, if the element is damaged, you have a flaccid paresis or paralysis. That is, paresis means weakness. Paralysis is complete loss of that voluntary movement. Then you have reduced or absence of reflex. If you do a spinal reflexes testing, either you will have reduced or areflexia. And of course, the muscle tone is reduced or absent, which we call it as a hypotonia or atonia. And here, the muscle atrophy is quite early and severe. That is because it's a neurogenic atrophy. It's not a disuse atrophy, it's a neurogenic atrophy. So the particular movement of the limb or muscle is because of this element. If the element is damaged, that limb goes flaccid and its muscle tone goes off, and the reflexes are reduced or absent, and the atrophy will be a neurogenic atrophy, which will be very quick to happen. Whereas coming to the upper motor neuron, actually the neurons, the cell body, it is situated in the cerebral cortex, and the axons run through the entire spinal cord, and it connects to the lower motor neuron. For example, this is the lower motor neuron for the hind limbs. The upper motor neuron, the nucleus is here. From there, it gets connected to this area through the axons. So that's why we call as a long track sign. Whenever you say a human sign, it's a long track sign. So here, the cell bodies lies in the cerebral cortex or in the basal nucleus and brainstem. This is for the cranial nerves. And then its axon leaves the cerebral cortex and runs through the brain and through the spinal cord and synapse with the element. So whenever there is a lesion in the UMN, it is responsible for initiation and maintenance of that movement. So whenever there is a lesion, naturally that inhibitory action over the element is released. So the element will get exaggerated. Any act of the element will get exaggerated. That's why you get a spastic paresis or paralysis. And if you do a reflex testing, you will have an increased reflex activity or hyperreflexia, and you will have a hypertonia in the muscles. And in this case, the atrophy will be very much delayed because tone is there, but atrophy is due to disuse atrophy. It's not a neurogenic atrophy; it's a disuse atrophy. It takes longer time to happen compared to an element lesion. Okay. So this is just to correlate your spinal cord and the vertebrae. See here, it is not actually equal. The spinal cord segments and the vertebral segments are not quite equal. You see here it is T8 and it is T7 of the vertebrae. So in that way, a spinal cord is always ahead of the vertebrae. So what you see here, the red marked one is the cervical cord, which is C1 to C5. It has UMN, that is the axons for the forelimbs as well as hind limbs. UMN is here. So any damage here can cause UMN signs in both the limbs. Then coming to the cervicothoracic cord, you have LMN for the forelimbs and UMN for the hind limbs, because the axons run through this for the hind limbs. So involvement of both the limbs will be there. You will have UMN signs in the hind limbs and LMN signs in the forelimbs. That is a flaccid forelimb and a spastic hind limb. Here, both the limbs will be spastic. The next cord is the thoracolumbar cord. So T2 is your landmark. Anything below T2 doesn't have much problem with the forelimbs, except for a Schiff Sherrington. I'll explain you in the later slides. So this is the cervicothoracic cord, T3 to L3, which carries UMN for the hind limbs. And any lesion here will cause UMN signs in the hind limbs and normal forelimbs. Then comes your lumbosacral cord, which has L4 to S2 segment, which carries the element for the hind limbs and UMN for this area, this segment. So element for the hind limbs. That's a lumbosacral cord. And next comes your sacrococcygeal cord, which is this one, and you can see the spinal cord almost ends in L6, nothing beyond L6, and you can't distinguish this coccygeal segments. So that's the sacrococcygeal cord. These are the different divisions of the spinal cord. So in case of spinal compression, you can see a clear view of this is a longitudinal section, this is a cross section. These two are the vertebrae, and that is the intervertebral disc, and you see the nucleus there. And this is the extradural compression, where the nucleus comes out and compresses. And here it is the intradural and extramedullary. You see here, there is a mass or lesion here. And this is intramedullary, the lesion is right away inside the spinal cord. Just to give an idea. Okay. So that is about the basic anatomical divisions of the brain and spinal cord. Now we will enter into the proper neurological examination. So here first part is the mental status and behavior. You will observe whether the animal is active, alert, or it is dull, depressed, or tuned, what you call it as comatose, all those mental status and behavior observed. That's first part. Then comes your observation of the posture and body position at rest. First thing, you look whether there is any head tilt. Head tilt is something like this. See, one ear is lower than the other ear. That is the head tilt. Okay, one ear you can see it's lower than the other ear. Whereas head and neck turn is something like this. Both and head and neck is turned this way. This is head tilt is something like this, not turn. Turn is something like this. You see both head and neck is turned. Head tilt is a sign of vestibular disease. Head and neck turn is a sign of cerebral lesion. Otherwise, we call this as an aversion syndrome. I don't like you, I turn my head away. That is called aversion syndrome. Then you know about the spinal curvature. The spinal curvature, it can be a kyphosis or lordosis. You are well aware of it, so I haven't put any figure there. And regarding the decerebrate and decerebellate rigidity, I have pictures to show you all those things. Here is one, we call it as a wide base stance, which is more common with the cerebellar disease. Cervicothoracic spine cord lesions, all this can cause wide base stance. Just for balance, it makes that way. Of course, the terminologies I've used like hemi-inattention, hemi-neglect. In coming slides, I'll show you what it is. Then, of course, ataxia, all those things there in coming slides. Coming to tremors, of course, you all know about it. Epileptic seizures, you know. Myoclonus, you see in distemper. Myotonia, you know that. The cataplexy, which may not know, is that is the animal will be conscious, but still it will not be able to move its limbs. That is cataplexy. And head bobbing, usually you see this in case of like that, it bobs the head. It is usually seen in case of Dobermans at around 8 to 9 months of age, and as it grows, that sign goes off. That is this type of head bobbing you see, just as I bob my head. Okay, this is the decerebrate rigidity I have taken from this one. Is a decerebrate rigidity. Decerebrate is a severe midbrain or pons lesion. Severe midbrain or pons lesion. So, and here the lesion is in the cerebellum. The difference is both has opisthotonus and stretching of both forelimbs and hindlimbs, whereas you see the hindlimbs is not stretched, it is contracted. Yeah, this is a classical decerebellate and this is decerebrate rigidity. Both has some meaning. Then coming to circling, usually the circling is in the direction of the lesion. Which side the lesion is in, that side it circles usually. And if it makes a wider circle, usually it is something related to the cerebellum. And if suppose it is as vestibular involvement, the circling will be little tight. Okay, it won't go with wider circles. Okay. Then coming to hemi-inattention and hemi-neglected syndrome, it is something you see in case of a cerebral lesion. If one side of the cerebrum is involved, you will have the hemi-neglect on the contralateral side. This is a classical example. If you give food and the ball like this, it eats only one half. The other half will remain untouched because it doesn't recognize the world in the other side, and there is no world exists on the other side. On the contralateral side, it's usually seen in the cerebral lesion, especially in case of a space-occupying lesion like meningiomas. Okay, this is called hemi-inattention syndrome or hemi-neglect syndrome. Okay, Schiff sherrington, and this is due to a thoracolumbar injury usually. Okay, so whenever there is a thoracolumbar injury, what you expect logically is the forelimb should be normal, the hind limb should be spastic. But the initial part of thoracolumbar injury, you see the forelimbs will be little rigid and the hind limbs will be flaccid. The reason is there are some cells called border cells in the lumbar enlargement, in the thoracolumbar area, in the lumbar enlargement. These cells has an inhibitory action over the extensors of the forelimbs. When these border cells are damaged, that inhibitory action is released, thereby you cause the extensors of the forelimbs, and because of the spinal shock, the hind limbs will be somewhat flaccid. But as the disease progresses, maybe in the second day or third day or fourth day, the forelimbs will become normal and the hind limbs will become spastic, as you expect in case of a thoracolumbar injury. Okay, coming to ataxia. Ataxia is an uncoordinated gait. You all know about it. An efferent kinetic deficit in the peripheral nerve or in the spinal cord. Or it can be a vestibular disorder or it can be a cerebellar disorder. This one, usually this one showing an hypometria of the hind limbs, you can see. And this one showing hypometria as well as dysmetria. Okay, as well as the dysmetria. Just watch this. Hypometria is somewhat a shorter protraction of the face of gait. You will have short steps, and hypometria you will have abnormally longer steps, something like goose stepping gait, you call it as. So just watch those videos. This is all. This video got through WhatsApp, sent for reference. This is a shorter protraction, which is hypometria. You can see the video down. Just watch this one. As it goes out, you see how the hind limb is moving. Okay, and this one as it. There you can see this. I'll stop this video. Concentrate on this one. You see a shorter protraction face of the gait. Okay, that is about ataxia. Coming to paresis, it is defined as a weakness or inability to generate voluntary movement. And paralysis is something complete absence of the voluntary movement. It can be involving all the limbs, tetraparesis or tetraplegia. It can be hind limbs only, paraparesis or paraplegia. It can be involving one limb, monoparesis or monoplegia, or one side of the body, hemiparesis or hemiplegia. And it can be a spastic type of paresis or flaccid type of paresis, or spastic paralysis or flaccid paralysis. Okay, I'll just rush through the Horner's, what it is. The Horner's syndrome is a lack of sympathetic innervation to the eye. So it can be from central, that is from hypothalamus to the runs down to the spinal cord, or it can be preganglionic phase. I've shown you that sympathetic preganglionic area, or it can be postganglionic. Most of the time, it's of uncertain etiology, or it can be seen also with the peripheral vestibular disease or with the C6 to T2 lesion, that is cervicothoracic cord, or with the brachial plexus injury outside the spinal cord. The clinical signs will be, that dropping of the eyelids, that's ptosis, and you have constricted pupil, miosis, then you have prolapse of the third eye, as protrusion or prolapse of the third eyelid, then shrunken eye, which is the enophthalmia. Okay, so coming to the neurological examination, so these are some of the instruments you need. You need this hammer, you need the hemostat, and also a powerful light source like this. And coming to the cranial nerve, you have 12 pairs of cranial nerves, you know that. Starts with olfactory, optic, oculomotor, trochlear, trigeminal, abducent, and facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. You can remember it in any way you like it. There are a lot of ways you can remember. You would have studied in anatomy. And most of them, you see, except for the 1, 2, and 1 and 2, all the other cranial nerves are all coming out from the brainstem. That is starting from 3 to 12. So any brainstem lesion, you expect a cranial nerve deficits. Okay, if it is a medulla area, most of the cranial nerves starting from cranial nerve 6 to 12 originates from there. So naturally you should have some cranial nerve lesions there. Okay. And these are some of the functions of the cranial nerve. Just I want to summarize in a single table, that's why I made it. And this is olfaction, this is for vision, and C3 is for the extraocular muscles, motor, and also the paracerebral innervations for the pupil. And 4, it's for the motor of the dorsal oblique muscle of the eye. 5, of course, the muscles of mastication, then tympanic muscle, and also sensory to face. Then 6, it is again for eyes. The 7 is for the face. Okay. And the 8 is for the vestibulocochlear function. And the 9, of course, 9 to 11, you know about it. Okay. Where the vagus, that's a major one. And of course, the 12th one is there. Coming to individual cranial nerve examination, it starts with olfactory. So what you do is you blindfold the animal and use an aromatic substance to check its olfaction. You don't use any irritants. Blindfold and do it, because just by looking at it, it can identify sometimes what it is. So it's very difficult. Without blindfolding, you can't do it. Then coming to optic examination, optic nerve, you do a menace or you do an obstacle test. Those obstacles you keep should not injure the animal. You should take care to keep plastic obstacles. And of course, pupillary light reflex. Then visual placing. Just go and touch the limb of the animal to the touch the table. It may move into the table. If you do, you can do as a blindfolding also, but visual placing is to test the optic vision. Then comes your oculomotor, where the PLR will help to to test the oculomotor. Your eye position is important. Your eye movement. Any nystagmus is there, that's more important. Then you have something called ventrolateral strabismus. It's depicted here in case of an oculomotor nerve. In case of a trochlear nerve, of course, trochlear is also important to the eye position. If there is a lesion, you have something, a dorsolateral strabismus opposite to it. Goes dorsal and outside. That's the menace, which tests the cranial nerve 2 and 7. How to do it? There's a video here. I've just demonstrated it. You don't poke it or don't create any. Still more, even you can do still more slowly. I'll run the video again. Still more slowly also. Just bring your hand in front of it. It should blink. Then comes your PLR. You just pass the bright light over the eye. That eye should constrict. This is called direct. And while testing this eye, the other eye is also constricting. That is indirect. And if direct is there in each eye, then no need to test for the consensual. If direct is absent, naturally you have to test the consensual. Then comes your trigeminal nerve, where you test the trigeminal nerve with the corneal reflex, palpebral reflex, then they're making a stimulus in the nasal mucosa, then pinching of the face with hemostat, and observing an ipsilateral blink or a facial twitch. This is the palpebral. Of course, cornea, same thing, use the buds, touch the cornea, it should blink. For a palpebral, you can do either way to the inner canthus as well as the outer canthus. This is, I've combined the nasal stimuli also. It's quite reactive. This is how you do a palpebral. Okay. Then, you have abducent. Abducent, you check the eye position. If there is any lesion, then you have an ipsilateral convergent strabismus on the affected side. And to test the facial, you have to do a palpebral, corneal, menace, pinching of the face, and if there is any facial, facial nerve involvement, then there will be an ipsilateral drooping of the affected side, and it cannot move his ears, lips, and also its eyes will be open like this. So here, if you are going to test any menace, it cannot move. It cannot. Vision should be there, but it cannot blink. You can't create any blinking, whether spontaneous blinking cannot happen, as well as you can't provoke any blinking there. Okay, that is because of the facial nerve involvement. Don't think it is blind. That's the facial pinch. That's even before I touch it, start reacting. So sensitive. Okay. Then comes your vestibulocochlear nerve. The signs related to this will be head tilt, falling, leaning, rolling, circling, or it can be an abnormal nystagmus. It can be positional or spontaneous nystagmus. You change the position, you can induce nystagmus. That is what we call it as positional nystagmus. And if you change the position, you create a strabismus, and that's called positional strabismus. Okay. So if it is involving the receptor organs in the inner ear or the vestibular portion of the vestibulocochlear nerve, we call it as a peripheral vestibular disease. Or if it's involving the lesion in the brainstem, we call it as a central vestibular disease. So how to differentiate between these two? While discussing about vestibular disease in the next session, I'll tell you in detail. But generally, it is the proprioception which differentiate mostly. It's the mentation and the cranial nerve deficits which differentiates from the peripheral from central. In central lesions, you will have proprioceptive deficits, you have cranial nerve deficits, and some change in mentation. But those things will not be observed in peripheral vestibular dysfunction. Okay. Coming to the glossopharyngeal, this you can't do in our animals, very difficult, you can't put inside. So there is a way to do. I'll just next slide is on that. So you have to check the glossopharyngeal by creating a swallowing reflex, and then for spinal accessory, you try to palpate the trapezius muscle. You just palpate the trapezius muscle, and then for hypoglossal, you just see the tongue whether it's normal in size and it's not asymmetrical, it's falling to one side, or if you try to stretch the tongue and see whether it's retracting the tongue, whether enough tone is there. So this is how you induce a gag reflex. It makes it animal swallowing. Yeah, of course I can feel. Yeah, now it moved the head like this. No, that shows it's swallowing. Then to check the jaw tone, you can do all these things in a matter of 10 minutes. Everything you can complete. Yeah, that one, right. Okay, so that is about the cranial nerves. Once you are done with the cranial nerves, then you do a postural reaction testing. It is something like that. It's a sense of kinesthesia, that is awareness of the precise position of your limb and the body movement. So you should know where your limb is. For that, you have receptors in the joints, in the tendons, as well as in the muscles, as well as in the inner ear. The inputs are collected by these receptors, and it is transmitted to the cerebral cortex. In the cerebral cortex, it's consciously perceived, and then it corrects itself. Suppose if you're doing a knuckling of PA, that is a proprioceptive positioning, it corrects itself because it senses that this PA is not in the right position. Okay, these are some of the tests you do: hopping, hemi walking, all those things. So one by one, see, this is hopping, and this is wheelbarrowing, this is proprioceptive positioning, this is tactile placing. You blindfold the animal, you put it on the table, it should, by touching the table, it senses, and then it walks into the table. And this is hemi walking. We'll see one by one. So this is conscious proprioception. So what we do is, we support the weight of the limbs, and then you try to change the position. So it consciously perceives that its limb is not in the right position, and this is carried to the cerebral cortex, to the spinal cord, and it corrects itself. So it almost tests the entire tract. So any subtle neurological deficits, we can bring it to light by doing a proprioceptive, conscious proprioception. And also it helps to differentiate between the neurological disease and the orthopedic disease. Very helpful. Then comes your hemi walking, just checking one side whether it is okay. That's hemi walking. Then you have hopping. It is to test the one limb whether it is having any weakness, lifting all other limbs and moving forward. That's hopping. In the larger animals, very difficult to do these things. And then you have wheelbarrowing. What I does initially is reverse wheelbarrowing. Then you do in the opposite way. That's the actual wheelbarrowing. So why you do these tests? This test will tell you whether there are any subtle neurological deficits, and it won't localize. It will tell you there are deficits. You want to localize it, then you continue doing a spinal reflexes. There comes the spinal reflexes for the thoracic limbs. It can be a withdrawal reflex or an extensor carpi radial reflex or a biceps and triceps. I'm not doing the entire thing, just selectively important 4-5 reflexes I'm doing. That is the extensor carpi radialis, which localizes the element that is C6, C7 to T2, as well as the connected peripheral nerves which comes out of this segment. I am hitting the belly with that, and you can see the twitch there. That is the extensor carpi radialis. Then your biceps and triceps, and it checks between, it localizes between C6 and C8. And when I just touch, hit the tendon, I'm holding the tendon right in the hand and I hit, and you can see the reaction from this biceps area. That muscles will twitch. Just watch it carefully. You see the twitch here? Yes, you can see the twitch here. Yes, that's the biceps. Then same thing for triceps. Just holding like this and hitting at this tendon, then you create a movement of these muscles. That is the triceps. And of course, you can do the withdrawal. Withdrawal I demonstrate for the hind limbs. Withdrawal nothing but pinching the toe, and then animal withdraws the limbs. And that tests that particular segment of the spinal cord involved. The whole thing, C6 and T8 in for thoracic limbs. Coming to the pelvic limbs, again you have withdrawal, patellar, gastrocnemius, and cranial tibial. This is the most reliable and important reflex in the veterinary medicine. This is called the patellar reflex. Very simple, hitting the patellar tendon, and you can see the extension of the top there. And this one, it's very easy to test, as you all know. It's very easy to test and more reliable also, and it tests between L4 and L5 as well as the femoral. Then you have a gastrocnemius, which localizes between L6 and S2. And I'm holding the belly of the gastrocnemius muscle and hitting my thumb. You can see the movement of that limb. Okay. That's the cranial tibialis. Again, this test between. Okay, this is withdrawal. Just I'm trying to I'm not pinching too much, little pinch I'm doing. So this limb is moving, but the other limb does nothing. But here you see the other limb is moving outward when I'm pinching here. This is called crossed extension. If withdrawal is there, it's fine. If there is a crossed extension, it means there is some human lesion. Suppose if it is in the forelimb, the lesion is above the L4 segment. So as per the classification, you have cervical cord, cervicothoracic cord, thoracolumbar and lumbosacral. Cervical cord carries human for both forelimbs and hind limbs. Cervicothoracic carries LMN for forelimbs and human for hind limbs. Thoracolumbar cord carries human for hind limbs and nothing for the forelimbs except for that Schiff sherrington. Then your lumbosacral cord carries LMN for the hind limbs. Okay. If there is a crossed extension, then the lesion is above L4. That is from L3 up to the cerebral cortex. It can be anywhere. Okay. Next comes your perennial reflex. Just to test S1 to S3, and you just pinch here, the anus should constrict. Then you have your panniculus. It's a sensory reflex. You do pinching all over and it starts here somewhere around L4 and up to this level. Okay, that's the panniculus. You can see the panniculus reflex, how it's reacting. See, it's a little overreacting, but generally it won't react. You see the twitch there, and you can relate with the same segment of the spinal cord where it is absent. From this level up to this level. To identify that the wing of that ileum will help you to identify from where to start here, the panniculus reflex. Okay, then the deep pain. So deep pain, you are using hemostat and crushing the periosteum, and you create a deep pain. It is not just taking off the limb, it should consciously pursue the pain and it should react. Either it should vocalize or it should try to bite you or do something consciously. So it tests the whole path, and this will give help. It is very much helpful in giving the prognosis of any spinal cord injury. The deep pain. The deep pain is absent. It carries a very poor prognosis. Okay. So based on these tests, starting from your observation which starts with the mentation, then your posture and gait, and then any normal movement. Then you try to do a cranial nerve examination. Then after cranial nerve examination, you do a spinal reflex, postural reactions testing, postural reflex testing. Then after postural, you do a spinal reflexes. Once you do this, you will get an idea of where to localize the lesion. So you have to check whether the where the neurological lesion is. Is the condition diffuse or focal, or it is symmetrical or asymmetrical? Okay. Suppose if it is a forebrain lesions, then you see changes in the behavior. Either it can be motor, visual, sensory, or emotional. And the other thing is, the important sign will be seizures. Okay. So coming to what are the neurological signs you see in case of a forebrain involvement will be, you will have a normal mental status to obtuse to demented to stupor. Not so common. These are some of the changes, especially in case of space occupying lesions of the forebrain, or in case of any inflammatory disease or a degenerative immune-mediated disease of the forebrain. Then you have a behavior, a normal behavior, or as I said, it's an hemi-inattention syndrome. And you, as I give a classical example, you give food in the bowl, the one half it will eat, the other half will be left untouched. So in that way you can identify it as an hemi-inattention syndrome. Or very commonly you see wandering, that is aimless walking, and then vocalizing, and will be very dull. Seizures may be present or absent. Posture, it can be a normal posture or an ipsilateral head turn, or as I said, it's called an aversion syndrome. It's a head and neck turn, and the horizontal carriage of neck, and also head pressing. You always see when there is an increased cerebrospinal fluid pressure, then animal will do a head pressing. No? Go to one corner and keeps its head pressing over there. That's called head pressing, which is an indication of a forebrain lesion. Coming to gait, the gait can be a normal gait or it can be an ataxic gait. And if there is a circling, it's an ipsilateral. That is same side of the lesion, it will circle and it will be a wide circling, not wandering, it should be circle. That is, and also it will just move here and there without any purpose. Especially when you see any lesions or metastatic lesions in the brain, you see these signs. Then comes the cranial nerve evaluation. You may see a contralateral perceptual deficits, especially for menace or for facial sensation. Other than that, most of the cranial nerves are coming out from the brainstem area, not from the cerebrum. Then you have postural reaction deficits, which is on the contralateral side usually. If the lesion is on the left side, you see the right side deficits. And spinal reflexes are usually intact, it won't get affected. And spinal hyperesthesia may be present, especially the cervical spinal hyperesthesia may be present, but not very usual. And pain perception, usually it's normal. And micturition, sometimes it may show some inappropriate micturition, otherwise it will be okay. Then comes your brainstem, and you have all the cranial nerves starting from 3 to 12, it all comes out from the brainstem. So you have the cranial nerve deficits, whichever area is involved, that particular cranial nerve will be having deficits. And usually you see human signs in the limbs. That's why I call it as a long track signs, just to introduce a new terminology. Then coming to the neurological signs of the brainstem, just a summary here. Coming to mental status, it can be normal, obtuse, stupor, and it can go to comatose stage. It's worse than your cerebral lesion. Okay. So usually you see coma here very commonly. And coming to the posture, it can be normal to a head tilt, which can be ipsilateral or contralateral, anything. And it can have a wide base stance. I showed you what is wide base stance. And it may exhibit a decerebrate or decerebrellate rigidity. So you see severe signs more commonly with brainstem lesions rather than with cerebral lesions. And gait, it can be normal or it can be a severe ipsilateral tetraparesis or hemiparesis, mild dysmetria, and usually all are human signs, spastic, because it's involving the brainstem through the axons run from the cerebral cortex. And you have ipsilateral deficits for the cranial nerves 3 to 12, which may get affected depending on the location of the lesion. It can have an ipsilateral or bilateral Horner syndrome. Coming to the postural reactions, it can be mild to severe ipsilateral deficits. Spinal reflexes, it can be intact or it can be an ipsilateral hyperreflexia because its human is involved. Spinal hyperesthesia present or absent. Pain perception usually intact. If it is comatose, you can't have pain perception there, depending on the mental status. Micturition usually intact. Severe lesion may manifest as abnormal micturition. You will have human bladder in case of a severe forebrain disorders. Brainstem disorder. Coming to the cerebellum, as you all know, as I said, it will have intentional tremors. That is, whenever it's going to do any eating or drinking, you will have the tremors developed, and you will have dysmetria and incoordination of learned motor tasks. All those things will be affected in case of a cerebellum lesion. In case of a cervical cord, C1 to C5, what it carries UMN4 for both forelimbs and hind limbs. So naturally expect all forelimbs involved, but usually it is the UMN signs in all forelimbs. You will have spasticity of limbs, and there may be neck pain in case of C1 to C5. This is a cervical cord because it carries the UMN, that is the axons of the UMN for both forelimbs and the hind limbs. Then comes your cervicothoracic cord. you will have the same thing. You will have quadriparesis or quadriplegia, depending on the severity of lesion. You will have something called root signature, because when the particular root is involved, impingement is happening, then you have signs something like this. This is called root signature sign, which may you think it's to a orthopedic lesion or a lameness, but actually it's a root signature sign. Then you can do a orthopedic examination also to rule out orthopedic lesions. And there will be varying degree of element dysfunction in the forelimbs. The forelimbs will be flaccid usually, and the hind limbs, it will be spastic. Okay, so this is the animal with the standing. It means it is having a paresis. When it is paralyzed, you can't expect it to have root signature sign. Then comes your thoracolumbar cord, which carries UMN, that is the axons for the hind limbs, nothing for the forelimbs except for the Schiff sherrington, that is the border cells here, which is having an inhibitory action over the extents of the forelimbs. Any lesion here, the initial phases of thoracolumbar injury, you may say a stiff forelimb and a flaccid hind limb. But as the disease progresses, this hind limbs will become spastic, the forelimbs will become normal. So it will have a paraparesis. Sorry, it is paraparesis actually, it's not paresis, and paraplegia. And you will have UMN signs in the rear legs, of course, a spastic type of paralysis, and you will have back pain there. So you will have this some degree of spinal curvature. Then comes your lumbosacral cord, L4 to S2, which carries your element for the hind limbs. And from there it continues as spinal nerve and as a peripheral nerve. So paresis are paraplegia. The paraparesis are paraplegia, and element signs in the rear legs. Of course, flaccid type of paralysis. Of course, in case of sacrococcygeal, you have a minimal paresis. You see, just see weakness, not paralysis. And you'll have element signs in the tail, anus, and the bladder, of course. You all know about it. And all these lesions, of course, you know, when there is a peripheral involvement, when it is involving all the peripheral nerves, then you'll have a quadriparesis. If it is involving a single thing, then you'll have a monoplegia-like signs. Okay. This is a lesion, usually a neuromuscular disease. And if it is a single nerve is involved, then you have monoplegia, that's a peripheral nerve involvement, and you'll have both motor and sensory deficits there. Okay, compiling the signs of the spinal cord lesion, starting with mental status. All the mental status won't get affected because it is not involving either brainstem or the cerebrum. So just simply it will be normal. Then coming to the posture, it will be a normal, it can be normal, or if there is an abnormal, it can be wide-based stance in all four limbs, in both cervical and cervicothoracic cord. But here, these two will be falling like, okay. And there will be horizontal neck carriage in case of a cervical and cervicothoracic cord, which is not seen in this. Then comes your gait. So as you all know, it will be dysmetric, and the pelvic limb will be more involved than the thoracic limb. You will have a tetraplegia because of stiffness there. And it can be an ipsilateral or that is a hemiparesis or hemiplegia also. Depending if suppose one side of the spinal cord is involved, it can be a hemiplegia or hemiparesis. So, but you see a spastic both forelimbs and hind limbs. Here you see a spastic hind limb and a flaccid forelimb. Here you see a spastic hind limb and a normal forelimb. Here you see a flaccid forelimb. Then coming to the cranial nerves, it should be normal, or sometimes you see ipsilateral hardness. These two segments are involved in case of any injury or any myelitis. In that segment, you can see that. But here the cranial nerves will be normal. Coming to postural reactions, it will have mild deficits, a normal or a mild to severe deficits in case of C1 to C5. The same thing. Here also mild to severe deficits and also sometimes absent in both. That's postural reactions. Your conscious proprioception, your hemi-standing, hemi-walking, hopping, all those things. Of course, this will have a hyperreflexia of spinal reflexes. This will have a hyperreflexia in the forelimbs and hyperreflexia in the hind limbs. This will have hyperreflexia in the pelvic limb, that is the hind limbs, and this will have hyperreflexia in the hind limbs. And sometimes you will have a pseudo hyperreflexia. It's a compensation. If one limb is very weak, the other limb will compensate. You may have pseudo hyperreflexia. It is involving the caudal segments. Of course, spinal hyperesthesia, usually it won't be there, or if it is there, it will be very mild. Here it will be sometimes mild to severe. You will have seen the spinal hyperesthesia because, and here again it is mild, all mild to severe. Pain perception is usually normal. If there is severe lesion, there may be a loss of sensory perception in both. And of course, this too will be, it can have mild to severe sensory loss or complete absence. Coming to mixturation, usually it won't be affected, but it can have a UMN bladder. It can have a UMN bladder. That is, you will have a detrus or areflexia and a sphincter hypertonicity. So the bladder muscles cannot contract properly because if the areflexia, the sphincter will not open up because it is having hypertonicity. The same thing, UMN bladder in all these things, all the segments, but an LMN bladder here because the sphincter becomes hypotonia here, and up to this level the sphincter is hypertonic, so it won't relax. Here the sphincter will relax. So how to differentiate this UMN bladder and LMN bladder? If you can express the urine easily without any problem, it is the LMN. Even with the pressure you can't express the urine, that means the sphincter is not relaxing, that is the UMN bladder. Okay, so once you do all these observations, you need a neurological form. This form is from the, you all know about it, it's from the clinician's brief. You just do your initial observations, starting from seizures, your mentation, your circling, pacing, head pressing, head turn, up to 6 it is for the cerebrum, and of course head tilt it is for the vestibular signs, and head tremors it is usually for the cerebellar areas. So all these observations you can make in that form. Then you have all your cranial examinations here, starting from olfaction, vision, menace, all this tests I have almost shown you. So, and here it carries where it localizes. This carries where it localizes. So if it is eyes, then you have left and right in that way. You can mark here all these things. Once you're done, you just make a round circle over that. Then you do evaluation of gait, whether it's normal, whether it's a quadriparesis or paraparesis, whether it's hemiplegia or it's a quadriplegia or paraplegia, all those things, or simple ataxia of all 4 limbs or only the pelvic limb or only one limb is involved. You're trying to mark it here. Then you do a postural reactions of wheelbarrowing, hopping, conscious proprioception in both forelimbs and hind limbs. Then you do all your spinal reflexes here. Then you do the other additional examinations. Babinski is nothing but you give a scratch on the hind paw, you give a scratch and it should do like this way. Instead, if it does in the opposite way, there is some UMN lesion. This is Babinski. It's easy to evolve, you can try that. And of course, muscle atrophy or neck pain, back pain, all those things you're going to mark here. And once you marked it, you'll try to localize where the lesion is. Once you localize the lesion, you're going to write down your differential diagnosis. And of course, you have options of doing a CT or an MRI. Then you'll try to localize the lesion. And thereby, you try to localize. And once you localize and you identify the you diagnose the disease, then you will have your management plans here. Okay, so with this I complete. Thank you, Dr. Rajinesh, or somebody come in line.
Hatvet Pharma Private Limited is a pharmaceutical company with its head office at Meerut. It was founded on 29 January 2019 with a vision to provide affordable and quality veterinary medicine to our pet parents. Hatvet Pharma is doing marketing of veterinary pharmaceuticals throughout India. In a small span of 1 year, we have launched 51 products in the veterinary pharma industry to serve our clients. In future 1 year, we are planning to have a product basket of more than 100 products. Hatvet is different from other veterinary pharma companies as we don't have distribution channel. We understand the latest needs of market, and for this reason we have adapted to online module of selling our drugs to field practitioners. We are serving our clients by providing the required medicines at their doorstep without any middleman. We directly collect orders online, mobile app, WhatsApp, telephonic from our end customers, and we deliver the required products to their doorstep through our nationwide logistic partners Blue Dart, DTDC, TCI Express. We are happy to announce that in our client list, most of the leading pet practitioners of India are included. To assure the unbreakable faith of our clients in our company products, we look after the quality of products, starting from selecting the raw material for our final products, aseptic precautions during manufacturing, and proper storage of finished products till supply to the end customers to ensure quality of products. We are happy to share that Hatvet Pharma has been recognized at various business platforms. Recently, an article on Hatvet Pharma has been published in the leading business magazine, Business Connect. One more milestone in the success story for Hatvet Pharma is that the managing director of the company, Dr. Rajneesh Tyagi, has been awarded Young Asian Entrepreneurs Award at Bangkok, Thailand on 7th February 2020. Our vision states Hatvet Pharma to be a commercially viable leading veterinary pharmaceutical company in providing quality products affordable to various sections of the pet owners society. Our endeavor is to be a front runner in innovation and quality in the veterinary pharma industry. We see a very bright future for our company as we are working in pet industry, which itself is growing at a higher rate, approximate growth of 20% annually. We are regularly working on the knowing of needs of our customers to serve them in a better way. We value your support to Hatvet Pharma and are very thankful to all of you. We look forward for a very strong and long business association between veterinarians and Hatvet Pharma. Thank you.